A very good morning to all of you. I am dealing with basics of peripheral nerve stimulator, and I am carrying greetings from Shivsagar, which is around 400 kilometers east of Guwahati, and my place is very much famous for historic monuments. Greetings to all. First of all, I declare that I do not have any conflict of interest. I have taken written consent from the patient and the parents for videography and photography, and I am not propagating any companies at all. The four of the peripheral nerve stimulator, what we are going to describe in subsequent slides, is about the physiology, the machine itself, the needle, and the injected solution. Now, first thing always first. This is the resting membrane potential, which is around minus 95 millivolt. Okay. Now, if you apply a stimulus from outside, that is the peripheral nerve stimulator, they will give a direct current to the nerve. And if you apply a stimulus from outside to the nerve, it will cause depolarization. And once a threshold level of around minus 55 or 50 reaches, there is a constant firing of action potential through this nerve. And this constant firing of action potential through this nerve will cause effective muscle contraction. That will get the twitches like this because of this. And there should be a stimulus, and that stimulus we are giving by a peripheral nerve stimulator. Now, whether this stimulus is a simple stimulus, like you have touch and there is action potential? No. Ladies and gentlemen, the stimulus should be a strong stimulus. But at the same time, that strong stimulus should be applied for a sufficient period of time, then only it will produce action potential. So stimulus should be a strong, at the same time it should be applied for a sufficient time, then only it will produce action potential in nerves, and that is the basis of peripheral nerve stimulator. Now, what are the end motor responses we are looking for in peripheral nerve stimulator machine guided nerve blocks? So if it is the intracranial, we look for the pectoralis major, deltoid, triceps, biceps, any two contraction. This is the end motor response. Then we deposit the local anesthetics. Okay. And if it is supraclavicular, we go for the flexion of the fingers or the wrist. And this is the musculoskeletal response, flexion at the elbow. Okay. And this is the flexion of the finger for median nerve stimulation. And this is the extension of the finger for radial nerve stimulation. If it is axillary block, you look for the flexion of the fingers or finger movement. But if you want to go to multi-stimulation, you can look for these twitches. This is the radial twitches. And this is ulnar twitches. You will get the apposition of the thumb and the little finger. You see? This is a little boy, thumb of egg, and the little finger. And if you are going for a lumbar plexus, the end motor response, where we are going to deposit the local anesthetics, is the quadricep twitches. This is the quadricep twitches. This is the end motor response for lumbar plexus. Okay. Now, if it is a femoral, we look for the femoral twitch, patellar dance. Then we deposit local anesthetics. This is the common peroneal dorsiflexion, which is not our desired response. This is the plantar flexion, and we deposit local anesthetic there. But not only the peripheral, we can go to the central blocks also, like the paravertebral block. You can use peripheral nerve stimulator, and according to the needle insertion, we'll look for the twitches, and twitches will be the abdominal and intercostal muscle twitches. These are the twitches we are looking for. These are the end motor response at 0.4 milliamps. And even if for the abdominal block, like iliohypogastric block, you can use this peripheral nerve stimulator, where you will get the twitches of external oblique and internal oblique muscle. These are the end motor twitches. So you have to know. But when you give this block or stimulation of the nerve, you are also hitting the sensory nerve. Isn't it? The peripheral nerves is a mixed nerve, contains both the motor and the sensory nerve. But patient is very much comfortable during the stimulation. You can see this boy, small boy, is getting the twitches, but he is very much comfortable. He is awake, not intubated, not sedated. So what is the reason? Because the peripheral nerve contains the sensory nerve also. The reason is you have to know about the rheobase and chronaxy. The rheobase is the minimum amount of the current which is required to stimulate a nerve. Below that nerve, below this voltage, it is not possible to stimulate a nerve. That is called the rheobase. But if you apply a current twice of the rheobase for a certain period of time, that is called the chronaxis. The chronaxy, there is a role of duration, but in the rheobase there is no role of duration. And this chronaxis refers to the excitabilities of the nerve. Now this motor fiber, it is highly mild in the nerve and this is easily arousable. See, at a duration of 0.1 millisecond, this is easily stimulated. But the sensory nerve, which requires a larger current, as well as the larger duration of the intensity of the current to stimulate the nerve. That is why when we are stimulating a motor mixed peripheral nerve, we are easily able to get the stimulation of the motor nerve, but at that same current, it is very difficult to stimulate the sensory nerve, which carries the pain fiber. That is why patient does not feel any pain or discomfort during peripheral nerve stimulation. Now, the ideal nerve stimulator should have the ability to change these settings. It should not be fixed settings. There should be safety alarms. There will be connection. If the circuit is complete, then there should be acoustic as well as the optic view that the machine is working fine. Now sometimes the circuit is complete, but the needle is not transmitting the electricity. Sometimes it happens, and it should tell you, the machine will tell you from the distance, oh the machine is not working properly, the needle is not working properly, something going wrong, and that should be the safety should be there in machine. And the current should be monophasic and rectangular, means the current should go from machine to the patient, not from the patient to the machine. And it should be constant current generator. Because the machine, the electric cables, the electrodes, the skin, the subcutaneous tissue, the needle tip, this will all contributes to a variable impedance. So once you are setting a current of 5 milliamps in a peripheral nerve stimulator, and all these tissues, the needles, etc., that will decreases the current strength. So the machine, the ideal nerve stimulator should not decrease that current. Means if you are setting a current of 5 milliamps, the nerve should be hit at 5 milliamps of current. So every machine nowadays is a constant current generator. So the machine itself, so when you switch on, you will get a 00. It should display the amplitude, it should display the duration of the current, it should display the frequency of the current, it should display the resistance of the current, it should tell the battery status, and it should display 00 once you switch on the nerve. And this is the positive end, which is attached to the patient, and it is always the red color, and it can be attached anywhere of the patient. In this case, my hand it is attached to the this is the positive end, and this is the negative end, which is a black color, and it is attached to the needle, and it is a negative. N for N, negative, needle, positive, patient. This is the set current, and this is the patient current, what the patient will get. Now the circuit is not complete. Here the beep sound is there, as well as this color coding is there. And once we complete the circuit, there is a change in the color as well as the beep sound. Okay, so this I am completing the circuit. So I am attaching this negative end to my hand, and this is the positive end to the pen, and completing this circuit. So that is the, in a nutshell, a peripheral nerve stimulator. Now you should have the ability to change these settings. You should have the ability to change the milliamperes, means the amplitude of the current. You always start for a superficial block at around 1 milliamps, and for deeper blocks you can go about 1.5 to 2 milliamps. Then you should ability to increase or decrease the duration of the current. It is the millisecond. For the motor nerves, you set the machine at 0.1 millisecond. But if the patient has sensory neuropathy, diabetic neuropathy, you can increase the duration of the current up to 0.2 millisecond or 3 millisecond. This is the frequency, means the impulses per second. If it is a 1 hertz, means 1 impulses per second. 2 hertz means 2 impulses per second. But ideally, we go for 2 hertz per second. That is the 2 impulses per second. And the newer machine, they are coming with a sense technique, that is a sequential electrical nerve impulse stimulation. Here what we apply, the first one is the 0.1 millisecond current, second one is the 0.1 millisecond current, and third one is the 0.2 or 0.3 millisecond of the current. So the third one will be longer duration current. So it will give a path to the anesthesiologist, in which direction needle have to go, it will give you the idea. And once you are in the nearby to the needle, there will be 3 contractions, tuck, 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 like the 3 rhythmic contractions. Now, initially we set the current at 1 milliamps and we look for the twitches. Now we gradually decrease the current and we look for the twitches at 0.4 milliamps. And if we get the twitches at 0.4 milliamps, we inject the local anesthetics. What is the science? That can be told by this Coulomb's law. If you rearrange this Coulomb's law, it will be the intensity of the current is directly proportional to the distance of the nerve and the needle. It will be the square root distance. Okay, this is the current intensities and this is the needle. And if it is far away from the nerve and the needle tip, it requires larger current to stimulate the nerve. But if it is close to the nerve, it requires lesser voltage of the current to stimulate the nerve. And that is the basis, that once you are getting the twitches at 0.4, means your needle is very much close to the nerve. But if you are getting the twitches at 0.2, it does indicate your needle may be in the intraneural position. So you have to withdraw the needle slightly. Now what about the stimuplex needle? This is the special needle which is having this coated needle. It conducts the electricity, but this shaft does not conduct the electricity. Only the tip conducts the electricity. And in each 1 centimeter marking, 1 centimeter apart, the markings are there, black markings are there. And the available needles are 5 centimeter, 10 centimeter, and 2.5 centimeter. And this is the clear, transparent injection port or extension port. It should be clear enough and transparent, because when you inject the local anesthetic and you aspirate, if there is a blood, it should be visible to you always. And this is the point where the machine is attached. Now previously the needle was not coated. You see this whole needle is not coated, but this nowadays what we are using a coated needle. If you use uncoated needle, this all shaft will disperses the electricity and it requires larger current to stimulate the nerve, number one. And sometimes you pass the nerve and then only you will get the twitches from this shaft. So it will give some block failure and sometimes the nerve injuries also. But nowadays we are using a coated needle where only the needle tip is giving the electric current. And because to prevent the nerve injuries and etc., we are using blunt 15 degree or 30 degree needle. Now at 0.4 milliamps you are getting the twitches, then you are depositing the local anesthetic. Once you deposit local anesthetics, the twitches disappears, and that is called the positive RAS test. You see, there are the twitches, and once you moment I give the local anesthetic, this twitches disappears. This is called positive RAS test. And this positive RAS test, it does indicate the needle is in the proper place. But thing is that if you inject local anesthetic, twitches disappears. If you inject normal saline, twitches disappears. But if you inject dextrose saline, not the dextrose solution, the twitches does not disappears. Previously it was thought, because once you inject the local anesthetics or solution, it will increase the distance between the needle tip and the nerve, and that's why it is very difficult to stimulate the nerve. But if so, the why there is the twitches does not disappear when you inject the dextrose solution? The answer is, does the injected solution conduct the electricity or not? Local anesthesia, yes, it conducts the electricity. Normal saline, yes, it conducts the electricity. But dextrose, it does not conduct the electricities. Okay? Once the electricity passes through the LA and the normal saline, it disperses the normal saline to sodium and chloride ion, and it disperses the local anesthetic into positive and negative ion, and that will form a ionic curtain between the needle tip and the nerve, and that is why it is very difficult to stimulate the nerve. So, ladies and gentlemen, the PNS, it is an adjunct only. It is not a substitute to RA anatomy. it cannot be used if the patient is getting muscle relaxation, skeletal muscle relaxation. It can be used in the central neurological blockade, beyond peripheral. So you can use in the paravertebral block, you can use in the caudal epidural, you can use where is the epidural catheter, whether in the subarachnoid space, whether in the subdural space, or it is somewhere else. But remember, it can be used easily in post-episode. If the patient is getting spinal anesthesia, you can still hit your femoral nerve block for post-operative analgesia. So ladies and gentlemen, King Kong with an PNS, always a King Kong. So before bombarding on these peripheral nerve stimulator blocks, you have to know your machine well. Thank you very much.